Keep going. With mitral valve replacement therapy, it's actually very important to get early to prevent muscle dysfunction. Survival basically is improved if it's done with a loss of EF of less than 60%. Symptomatic patients should have surgery even if normal EF. Okay, so it's really one of those things that you should really get this person in the operating room the sooner the better. Mitral valve repair tends to be the preferred treatment now. They've actually shown that it actually improves survival. Mitral valve replacement is done with valves that have significant disease or patients that have decreased EFs. Patients with a decrease of EF of 30% or end systolic measurements of more than 55 millimeters basically do not improve the replacement, and that's the sad part of it. So if you wait too long, you don't improve. Okay? The thing is, at least you stop the progression of the disease, hopefully. One of the things that will happen if you get down to those low levels is that the actual pulmonary hypertension becomes an issue, and then you got poor outcomes. Okay? Medical management is really not, this is not a good medical management problem. This is a surgical problem that needs to be corrected. For medical management, asymptomatic, no change. Symptomatic, improve with ACE inhibitors, beta blockers, and biventricular pacing. My point to this is stay away from this, go to surgery. It's really safer for the patient in the long term. Mitral regurgitation management is prevent bradycardia from developing. If you do have too much slowing down the heart, you end up ejecting more volume into the left atrium. You also want to decrease your SVR, not increase it. Patients that have drugs that minimize myocardial, that get myocardial depressant drugs will also exacerbate the problem. And you can actually monitor the degree of regurgitation with either PA catheter by looking at your PA waveform or do an echo. Okay? Most of us will do a TE in all these patients, of course, because they are going to get the mitral valve replacement. You might as well see how the mitral valve looks after it's been replaced. You want to make sure that the valve is well seated, that it's functioning properly. Sometimes you even see terrible things like the valve is actually sewn in backwards, which was also a very bad day. What happens is if you get bradycardia, well, with bradycardia, you'll get the left atrium will begin to fill more, okay, more of the ejection, and there's more time spent in dilating the heart. So as a consequence of mitral regurgitation, it gets worse. So it's a double whammy, so it's something you don't want to do. If you increase the SVR, the preferential route of blood flow, instead of going out to the aorta, will be out into the left atrium, which then makes pulmonary hypertension worse and develops in pulmonary edema. And myocardial depression, simply, if you depress the heart, it becomes stiffer, and it's just because it becomes stiffer, the mitral valve is able to remain in a more open state, and again, more volume goes into the left atrium, and you get worsening symptoms. For mitral regurgitation, we already went through that, so I'm not going to go with that. Okay, decrease anxiety, do not use beta blockers, it's not well tolerated, and hypertension is not well tolerated either. Induction, do not increase SVR or induce bradycardia. Neuromuscular blockers, such as Valvular, are actually a good choice because they actually may increase heart rate for you. Maintenance, volatile anesthetics are considered safe. The opiates, avoid the narcotic-induced bradycardia, so you want to make sure that you add Valvular if you are going to use high-dose narcotic. Mechanical ventilation is you want to basically maintain normal PCO2 and pH and give adequate times for venous return and avoid dehydration in these patients. Monitoring is usually normal monitoring if you're not doing anything very severe. If you have severe MR, you need to put in a PA catheter and A-line. Expect the big V waves, okay? Especially when you're reading your PA occlusion pressure. Don't read it by looking at where the V wave's at, but rather where the C wave is at. The true reading, which is if you have normal AC, will really give you the true volume that's inside the left ventricle, and that's how you should treat it based on that, not based on the V wave. The V wave will be very enlarged, and its consequence will give you a reading problem on the machine because it cannot differentiate between a large A wave and a large V wave. So the machine will actually think that the mean is higher than it should be, which it is. If you look at the CVP yourself, then you know where the volume is at, and you can base it on treatment on that. The next one is mitral valve prolapse, which is a very common valvular problem. Occurs more in women. The etiology could be many. Marfan's rheumatic carditis, myocarditis, thyrotoxicosis, and lupus can also, it tends to be mostly but benign, okay? It leads to complications such as strokes, infective endocarditis, may eventually form severe MR in the future, something you have to watch for, dysrhythmias and sudden death. Diagnosis is by echo or also by listening to somebody. And mitral valve prolapse is kind of tricky because it depends on the volume status of the patient. Okay, so sometimes you'll come into your office if you're a general practitioner and you listen to the heart and it would sound normal. But a week later, the person has more hydration, comes back, you got a lot more regurgitation taking place. So it comes and goes. The symptoms are also made worse by anxiety, things that increases your SVR. Okay, will cause acute regurgitation to take place. And that's why people that are very anxious, okay, about something, they get an adrenaline surge, SVR rises, okay, and because of that the mitral valve opens more and causes regurgitation back into the actual left atrium, which then causes volume to be displaced back into the lungs, and the lungs get heavier and the person feels it and they get dyspneic, okay, so they get this anxiety panic disorder. It's actually just due to the mitral valve prolapse. Yes? Good question. The difference is that it's a degree. Okay? With mitral valve regurgitation, the actual valve is open and stays dysfunctional throughout. Okay? In mitral valve prolapse, it depends on certain situations for the valve to lose its ability. I would say mitral valve prolapse is like a low-grade MR. Okay, most of the time. Okay, but it acts a little bit differently than normal mitral valve regurg in some ways. Treatment is a lot of times these people get put on beta blockers and then all the symptoms go away. So it's really, you want to avoid the beta blocker effects from the epinephrine and norepinephrine. It's based on echo, consider sometimes anticoagulation as well. But most of the time, mitral valve prolapse don't require anticoagulation. Left ventricular emptying worsens with mitral valve prolapse. Okay, what increases left ventricular emptying as you want to avoid, so it increases systemic activity, sympathetic activity that increases myocardial contractility, decreased SVR. Assumption of upright posture also makes the situation worse in hypovolemia. Preoperative medications continue the beta blockers, continue the antihypertensives, and avoid the diuretics. Induction, watch for tachydysrhythmias, again, just like mitral valve regurgitation. Tolerates general anesthesia and just fine. The mild anesthetics tend to have some depressant effects on the heart, which is beneficial. And remember to keep the heart full, less mitral valve prolapse in this situation. Yes? Why would you want to Okay, this is a different disease process in mitral regurgitation. Okay? In mitral valve prolapse, okay, let me go back and see where it's at, right here. Things that make the situation, what increases left ventricular emptying you want to avoid, okay? So things that will increase myocardial contractility, okay, which empty out the left ventricle, the mitral valve regurgitation becomes more prominent when the actual volume inside the ventricle actually gets smaller, okay? Versus mitral regurgitation is the other way. It's when you dilate the heart, that's when the mitral regurgitation gets worse. Okay? So mitral valve prolapse is actually a prolapsing effect upwards. Okay? Versus mitral regurg is a separation of the valve this way. Okay? So when you fill the heart too much, the annulus, which is the actual valve ring, will actually pull apart and open up cause mitral regurgitation to be worse. But in mitral valve prolapse, the valves are touching each other, okay? But what's interesting about the mitral valve is that you have two leaflets, okay? There's the anterior leaflet and the posterior leaflet. The posterior leaflet is really small. It's like a little knuckle, okay? And the anterior leaflet is large, okay? What happens if you have low volume states, that posterior leaflet flips up. Okay? And when it flips up is when you get regurgitation to take place with the mitral valve prolapse. So it's a different pathophysiology than regurgitation. Okay? In mitral valve prolapse, it's due to a low volume state that you get this flipping of the valve. So the more full you have that person, the less symptoms you get. Okay? So somebody who has, increased sympathetic discharge and you get increased contractility. Okay? That empties the heart more, and it makes the mitral valve prolapse worse. Okay? If you make the person's heart rate go faster, you empty out the left ventricle, you make mitral valve prolapse worse. Okay? A low preload state, such as dehydration, makes mitral valve prolapse worse. Versus mitral regurgitation is the right thing to do, is to reduce the volume. So it's a different disease process. Okay? Slower heart is better. It keeps the heart fuller in this situation, so you get less mitral valve prolapse. Okay, yes? It actually does sound the same, depending on the situation it's in. Yeah, it will sound just like a regurgitation murmur at times. Yeah. That's a tricky part. Okay? And unfortunately, the literature doesn't explain mitral valve prolapse too well. They tend to tell you that it's very similar to mitral regurgitation, but they don't tell you the differences. The differences has to do with one is a low volume state versus the other one's a high volume state problem. Okay? One has actually normal valve architecture. Okay? In the people that have mitral valve prolapse, they will eventually progress. Sometimes, not always, but a great percentage of them will progress into mitral valve regurgitation. Okay? What reason for that is because their valve is not normal. Okay? The valve shouldn't, at low volume states, flip back on you. Okay? That means that the chorda, which are holding it, are loose. Okay? They're too loose. Okay? So when the volume falls in, then the structural element that holds it will flip back and allow the regurgitation to take place. Okay? So eventually, over time, as you keep stretching this guy, he eventually gets stretched. So when you get more volume, now the valve begins to fail and cause regurgitation as well. So a lot of people will tell you that mitral valve prolapse progresses into regurgitation, and their answer is right. Okay? But it takes many, many years. You could be somebody with 40 years of mitral, or their whole life with mitral valve prolapse, and they don't develop symptoms of mitral regurgitation until they're 70 or 80. Okay? Versus somebody who's developing mitral regurg at 20 due to some kind of problem, then they're going to progress pretty quickly over 20 years. Okay? Yes? Yeah, very similar. Yeah, pretty much. Some of them are very similar to each other, and that's one that would be very similar to IHSS. Low volume state would not be something you want. Right. You don't want too much of a low afterload for mitral valve prolapse, because then you basically unload the heart again. Anything that basically drops the volume in the heart is a bad thing with mitral valve prolapse. Anything that drops the volume down with mitral regurgitation is actually a good thing. So it's a reverse. And that's why I made sure that you understood the differences between these two. So, this is not, if you make the assumption this is the same thing as mitral regurgitation, and you get the person in the operating room and you dry them out with diuretics, because you think that person may be, more symptomatic if they get more wet with more fluid, that's not the right thing for mitral valve prolapse. You're going to get yourself more into trouble. Okay? Does that make sense, or I lose anybody? Yep. It's also going backwards, but what happens with mitral valve prolapse is that normally in the initial portion of it, the valves are together. This is the short valve, the posterior valve. This is the long anterior valve. Okay. What normally will happen is when you're going between doing systole is that this valve closes tightly. Okay. In mitral regurgitation, what literally happens is you have a spreading effect. Okay. So the valve still tries to touch, but it's still failing because of separation and distance. So when you get dilation, okay. Sometimes when you get mitral regurgitation from rupture of chorda tendon, you get flapping back of the valve completely. That's very severe. Okay. With mitral prolapse, the posterior valve, which is much smaller than the anterior valve, what it tends to do is it tries to hold it, and it holds it fine when you have adequate volume, because the chorda tendon is stretched just properly. But in a low volume state, see what my arm's doing? Okay, that's the papillary muscles basically stretching, and what's happening is my valve is opening. Okay, so just by doing this, I actually am making the length shorten up, and the cord attendant a little too long, and then the valve peaks up open during portions of systole, which then causes that regurgitation fraction. So it's in a low volume state that you see that, okay, not in a high volume state. Okay? So hypovolemia, low volume states all make mitral valve prolapse worse. Okay? Beta blockers are of course good for this kind of situation because it actually allows for prolonged filling of the heart and prevents the mitral valve prolapse from taking place. Antihypertensive therapy is you have to be cautious with it. You want to make sure that you don't drop the afterload too much because then you empty out the heart too much. So it has to be under tight control. Most of the time they use beta blockers primarily for this. Avoid diuretics as well because it drops the preload volume inside the left ventricle. Induction of watch for tachydysrhythmias. They tolerate general anesthesia and regional just fine. Volatile, the only thing is make sure that the volume is going up as you're giving the regional. Volatile, also the depressant's effects are beneficial because it basically prevents the heart from emptying properly, so the mitral valve prolapse is less. And remember, keep heart full and you get less mitral valve prolapse. Etomidate is actually a good choice, and ketamine may actually also be a bad choice due to sympathetic stimulation, which causes an increase in tachycardia. Minimize sympathetic nervous system, so make sure you give adequate amounts of narcotics. A good combo is volatiles, nitrous, and opiates. Neuromusculars, watch for histamine release because it drops your SVR, okay? And sympathomimetics may be needed as well. Maintain adequate preload and avoid hypotensive technique in these patients because they will get worse with hypotension. Normal monitoring, usually only if MR is present, you consider invasive lines. So in other words, the mitral valve prolapse has progressed now into mitral regurgitation, then you may want to consider invasive lines. They have somewhat of an increased risk of endocarditis because it is a valvular dysfunction, so some people will actually give these people antibiotics. The next one, which is aortic stenosis, is the most common left ventricular outflow tract obstruction. You have, of course, valvular aortic stenosis due to congenital, which is bicuspid valve, which is what this is. The reason bicuspid valve causes problems is because there's increased flow velocity, and anytime you increase flow velocity, there's more disruptive turbulent flow, which causes damage to the valve. Okay? Rheumatic disease can also cause problems because it begins to pocket the valve, which then causes calcium deposition and eventually increased degeneration of the actual valve. You can see here, this is a really nice picture showing you actually the degeneration. Okay? This is where the actual coronary arteries are actually exiting, the left and right. Okay? And this would be called the NCC, which is a non-coronary cusp. The valve, as you can see, is becoming calcified on the outside, and that's how it normally starts. It never starts in the middle. It actually moves from the outside inwards. And you can see this person's valve is significantly stenotic, and it's down to only a very small portion of the non-coronary cusp is actually the only valve that actually is moving. The left and the right coronary cusps are actually fused, and now you're left with a very narrowed space. Okay? These can be very, very impressive when you go in there and have to cut it out. I've actually seen a surgeon break their scalpel trying to get one of these things out, so that's how heavily calcified they can be. It's not a joke. Okay? The other downside to this is because the calcification will leave little calcium bits after they cut it out. That can embolize, which has devastating effects. So you really have to have it well cleaned out before the surgery is finished. A normal aortic valve is the size of your thumb, which is around 2 centimeters squared. It usually becomes symptomatic when you lose the space down to 0.8 centimeters squared. The lowest I've ever seen somebody was down to 0.2 centimeters squared, which is pretty impressive. The aortic sounds was 0. You couldn't hear any aortic valve sound anymore. That was even more impressive because everybody said, oh, he's got severe AS, and so I was expecting to hear a great murmur. I put my stethoscope on and I heard nothing. That really scared me, okay? Because then I realized, wow, how many times did this happen to me? You put in a regional and you don't hear anything. So, but the thing is, everybody's symptomatic at that point. these people are having significant problems at that point. They get chronic obstruction of the left ventricle because of that. They get pressure overload conditions, so they get left ventricular hypertrophy. You get significant increase in muscle mass, so you'd see an EKG a very significant QRS. Okay, you see a stiffer, less compliant ventricle, which requires very significant amounts of left atrial kick to fill it properly. The atrial kick accounts for approximately 40% of the left ventricular end-diastolic volume in these patients. The other problem with it is because you're increasing left ventricular end-diastolic pressure, you're increasing the risk of ischemia because you're limiting the coronary perfusion pressure. There's also an increased risk of myocardial workload due to increased mass. That also increases the risk for ischemia. In Goldman's study, aortic stenosis was considered one of those high-risk procedures. Increases the risk of any perioperative complications, and it's independent to the risk attributable to atherosclerotic coronary artery disease. So it's individually by itself at high risk. Heart sounds that you get is what's called the crescendo decrescendo. Remember, you'll sound like something like this. Goes up and down. Okay, it's pretty pathognomonic. You hear it over the aortic zone. Okay, so when you hear the stethoscope, you should break up your heart: aortic, pulmonic, mitral over here, and then you hear tricuspid. Okay, so you can actually hear the different portions of the heart by where the location of your stethoscope's at. Clinical implications, clinical findings, you get angina. If you have patients developing angina and they could have a normal atherosclerotic, normal coronary arteries at that point, believe it or not, they have a 5-year survival rate, okay, 50% mortality rate in 5 years. If the patient develops orthostatic exertional syncope, which means they're losing consciousness when they try to get up, they have a 3-year 50% death rate. And then if you have dyspnea on exertion, now you're down to 2 years. 2 years to have a 50% mortality rate. So that's not good. Okay? Most people are dead if you don't do anything within 6 to 8 months. So that's not a good thing to have. It's 50-50, but it goes to 5, 3, 2. So every time you drop down a year, it increases the risk. Okay? At 5 years, 50%, that means you can lose 10% per year. If you're at 2 years, you're looking at 50% per year of dying, almost. 25% per year of dying. And so 25% of people would be dead by the first year, and another 25% would be dead in the second year. Okay, so that shows you the risk is going up. Okay, echo. This is more for when you get to clinical. So you have something when you hear what a transvalvular gradient is. Okay, transvalvular gradient for ARS is considered 50 is severe, and the aortic valve area is around 0.8. Okay. Now, what is a gradient? Okay, let's go into that. A gradient is the difference between what this value is here. This is a person with a normal valve here. Okay, so I've drawn this in here for you. The normal valve here is this is your ventricular ejection. Okay, and this is your, in green I'm going to draw here, is your normal or aortic waveform. Okay, that's normal. You can see that during systole, between aortic valve opening to aortic valve closure, that the waveform mimics the ventricular waveform. Okay, in this case there is no gradient, 0. It is normal. Okay? But let's say if you have somebody who has severe stenosis, okay? What happens in severe stenosis, the heart's going to continue working very hard to push volume out, okay? But the valve is really impeding that. And what will happen is you'll get this effect. So that's your ventricle. I'll put this in the ventricle. And what happens to this person, the aortic pressure looks like this. Okay? This difference is a gradient. So you're doing a ventriculogram. You're doing a ventricular pressure monitoring of the left ventricle, and then your pressure monitoring in the aorta. And that difference between the two pressure peaks is called the transvalvular gradient. Okay? Now, what you see with aortic stenosis in the pressure volume curve is that the valve here doesn't open properly, So you get increasing in SVR. Okay, so this person goes up, okay, ejects, and then comes back down. Okay, so the actual volume ejected actually drops in this patient. Okay. Now, what the compensatory mechanism, if we want to go into that, will be that it'll develop hypertrophy, which means that the compliance of the ventricle actually drops off. So what you'll see is you'll see an alteration in your preload curve from here to here. Okay? When you do that, you actually improve the contractility. Okay? So you get up to here, still the same point. Okay? But now because the contractility is also changed from here to here, okay, you see that the person ejects and then go back down. So that's a compensated aortic stenosis. Eventually, as the disease gets worse, it'll shift back to what I showed you in the original one, which is the red one. Okay? And that's one that I want you to sort of memorize for your test and never tell you about the compensated one because that stays fairly okay. It's the uncompensated that's where you're coming to the operating room for. Okay? Treatment of AS is medical. It's okay until they've developed symptoms. Once they do develop symptoms, you're looking at 75% mortality rate overall in 3 years. So that's not good at all. Okay? Surgical treatment is really what is needed at that point. Aortic valve replacement decreases the afterload and increases stroke volume. Balloon valvotomy, I'm still a big non-believer yet. Okay? The reason I'm a big non-believer is because guess what's right against the balloon? The actual coronary arteries. So when you put that balloon up, you occlude the coronary arteries so the person develops ischemia during the process. Plus, of course, the tremendous afterload increase that you see with this. There's actually things that are coming down the pike, okay, that you guys may see. I don't think I'm going to see it in my lifetime, but some of you will see it. And what they're doing with that is they actually will remove the valve with a mechanical device. So they'll rotor-rooter it out, okay, and then they'll put in a replacement without having to do open heart surgery, all transarterially. That's what I've heard recently that they're doing. They're working on right now in animals. That's pretty impressive. And when you see that, that means you don't have to take the person to the operating room. You don't have to do cardiopulmonary bypass, so the risk goes way down, supposedly. I still don't quite understand how you're going to capture all the fragments that you're rotor-rooting out. And watching surgery for many years and watching how much calcium deposition, it's going to have to be a heck of a big rotor-rooter system because that calcium is pretty tough to break loose. So, but it's interesting that they're considering doing that. This is what the actual surgical procedure looks like. This is a major, major procedure, okay, because what you're doing is you're actually opening up the aorta. And that's not a joke. Anytime you open up the aorta and play inside the aorta, you're playing with death in the sense that if you don't put the proper suture, something breaks loose after the operation, it tends to be non-survivable. Okay? You put this person on full cardiopulmonary bypass, okay? And then you do your cardioplegia, you do your cardiac standstill at that point, and you do a valvular removal, okay? So the valve's removed. And then they do, this is called a spacer or a sizer, sorry. It actually will determine the proper size to use. Okay? And then what you can see here is they have this post that actually holds the prosthetic valve while they're working, which makes it a lot easier. They used to just give you the actual disc, and you had to work with it in your hand. It was a nightmare. So with this new post, it helps somebody holds it while the surgeon just sutures through it. And you can see he puts in the different lines, okay? And then once he gets the sutures in, he just pushes it down, and they suture them one at a time until they're done, okay? And eventually you have these actual suture lines all the way around, okay? Now it's really cool because the echoes now can actually see that. In the old days, we could just see the valve. Now we actually see the suture line. It's really impressive, okay? And then once you're finished, they de-air the aorta, they refill it with blood, and we come off cardiopulmonary bypass at that point. Yep. The replacement of the root is a major undertaking because what they do in that situation is they replace the valve, they replace the whole root. Okay, so it's actually now one piece. In the old days, it used to be two pieces. You have to put the valve in, then you put in a Gore-Tex graft on top of it. The new kits that are coming now are one valve on with the aortic root. So it makes it a lot easier for the surgeon. Okay? What's that? Yeah, that's the other thing. That's what I was going to tell you next. The next thing that they have to do is they have to take the coronaries and detach it from the old aorta, okay, and put it onto the new graft. The downside of that is that it's never as good in flow value as it was initially, because the actual coronaries are not inside this nice annular specialized container that increases flow velocity through it. Instead, you're in an up and down chamber, so the pressure can only go sideways, and so there's a lot of turbulence. There's a little bit more problems with coronary blood flow in that situation. Yes, sir? Depends. Depends on your surgeon. We have very good surgeons here. They're some of the best I've ever seen, and that says a lot. I've seen a lot of good surgeons, but these guys are really good here, and they're doing the hearts. Two of them are excellent, above board. The other guy's still learning, but he'll catch up with them. He's very good too. But the two guys that we have right now, if I had a heart replacement, a valve replacement, I'd go to them first. Because I've seen them do aortic valve replacement in an hour and a half. That's flying. Okay, I've actually seen a guy do an aortic root replacement with a severe aortic dissection in 2 hours and 15 minutes. Chest to close. That's amazing, with a dissection. Okay, and the guy actually walked out of the hospital. That tells you the competence that you're dealing with. Okay, versus if you work in a training center, bets are off. Could be 8 hours. Okay, when I used to do our hearts, we used to kid around. If we can get these people off the table, we can get out. We're Lazarus. We're bringing them back from the dead. Okay, the worst situation I ever had in my career was the surgeon took out the mitral valve. And actually, you can look it up. It's actually in the literature. He took out the mitral valve, and in the process of putting it back, putting a new one in, this was before they actually had the post. He put in the mitral valve in backwards. Okay. The problem with that is if you put in the suture line too close to the annulus, okay, you actually will disrupt the actual infrastructure of the heart. So it was really when we looked at the echo when the guy came off, we saw no blood flow and the blood pressure was like 0. We were getting a little bit, but not very much blood pressure at all. And when I looked at the GE with my attending, I said, that doesn't look normal. The valve looks wrong. It looks like it's in backwards. And everybody sort of laughed and said, yeah, you're crazy. I said, yeah, it just doesn't look right, man. And we stopped, went back on bypass, and sure enough, we opened it back up, and the valve was on backwards. So they flipped it on the patient. Okay, when we flipped it and we tried to reinstall it, okay, the valve wouldn't go on properly; it would flop. So after doing this for about 4 hours, trying to get the valve to seat properly, and it couldn't, the surgeon decided to take the heart out of the chest completely and work on it outside the heart onto a Mayo stand. I'm not kidding you. This is real. Okay, now as a consequence after that, then we put the heart back in, and just like a transplant heart. Okay, then we were asked to resuscitate the patient and bring him back. You know, dead heart is a dead heart. Okay, you just can't take the light. You can't take the heart out of the chest and expect to put it under lights and expect the person to survive. So you can only do so much. I don't care how good an anesthetist you are. Okay, it won't matter. Okay, so it depends on your surgeon. Okay, but if you ever want to read about it, it's in the literature. The guy actually wrote about it. That's what even more amazed me. But it's the way it is. Now, what you can see is that these surgeries can be very complicated in the sense that you are going into the major structures of the body, which is the aorta. Okay, you have a tremendous amount of flow velocity of the heart. And coming off bypass is a critical part that will teach you once you get to clinical. The other thing that you want to know about this is that these people have a high risk of post-op bleeding, and a lot of times these people will come back. is around a 25% bring back rate for most of these cases. Some centers have a 100% bring back rate, and one surgeon that we had a 300% bring back rate. So, like I said, we were really good, okay, because we got used to surgeons that were not as good as the ones we have here. The bring back rate here is very small. It's only about 10%, which is way below the norm, okay, which is really good. Yes? No, not really. Most of the time the surgeon can tell if there's going to be any bleeding right up front. There's so much pressure going through the aorta that you can sit there and watch, and the bleeding will sort of jump out at you. It's really not like the only time where it becomes a problem is if we hit recovery room, okay, the ICU. The patient will then have hypertension that develops because they're awakening, or they'll start shivering and the cardiac output begins to increase. And then the suture line that may actually be a little bit weak, may rupture on you. That's when you see the massive bleeding, okay? So it's usually not in the operating room, okay? And what's really funny is by the time you take them back to the operating room, open their chest back up, guess what? You can't find the bleeding source most of the time, okay? Because it could be a small little artery that's been compressed and the blood pressure dropped back down, and now you can't find it. So a lot of times what we'll actually do for the surgeon is we'll drive the pressure back up to like in the 140s and see if it starts re-bleeding again. And sometimes they will show up that way, okay? But sometimes you just don't see it. So sometimes you bring back somebody maybe once or twice. That's really frustrating, okay? But usually it's 3 o'clock in the morning and you're kind of tired. You don't want to do it again, okay? I already went through that one. Anesthetic management, maintain normal sinus rhythm. It's very dependent on the atrial kick in these patients. Remember that 40% of the EF could be due to that, okay? Avoid bradycardia, avoid hypotension, optimize your intravascular fluid volume, and CPR is ineffective if the patient arrests, okay? If the valve is stenotic and you do CPR, it won't work. You can't get these people back, so don't get yourself there. General anesthesia is the preferred route. Regional anesthesia can be done by some cowboys. I don't think it's a good idea, okay? Unless you've got 20 years experience under your belt or 10 years experience doing lots of regional, don't even attempt this or don't even consider it. It's really relatively contraindicated. Most people would say it's completely contraindicated. A spinal anesthetic is completely contraindicated. You can't tell me any way that you can control a spinal, how fast it descends. An epidural, I might go along with you if considering it, but I would put somebody under general anesthesia in a heartbeat in this and not even think about regional. The only kind of regional I may even consider might be doing a regional block, but that'd be about it. Okay, almost everything else I do under all these people under general. There's just too much risk. If you drop the SVR, you have no more coronary perfusion pressure, and game's over. Okay? Is that because they already have a lower blood pressure? No, they actually have high blood pressure most of the time. Okay, the body compensates for that. What they don't have is the diastolic blood pressure. Okay, the diastolic blood pressure actually drops off on these people because the reason it drops off is you have limited diastolic time. Okay, so because of the limited diastolic time, you're filling only the aorta somewhat, not fully, and as a consequence, diastolic pressure drops, and that's what drives the coronary perfusion pressure. So if you give a person like this a regional anesthetic and you drop their SVR down, you'll drop their diastolic pressure down into a critical value, and then you won't have any coronary perfusion pressure. The person will get ischemic and then drop dead right in front of you. Okay, so it's not what you want to see. Okay. Maintenance, nitrous oxide is safe. Volatile anesthetics seem to be working fine. Neuromuscular blockers, just avoid more of the etracurium, which are the histamine-releasing drugs, all the benzoyl-quinolones. SVT may be terminated with cardioversion if needed, and ventricular dysrhythmias may also be considered treated with lidocaine or sometimes even defibrillation pads early. Monitor A-line, PA catheter, TE, it's pretty high. AI is the next one. AI etiology is infective endocarditis is by far the more common cause. Rheumatic fever as well, bicuspid valve also may cause this problem. And the new thing that is also common is anorexigenic drugs. The fen-phens during the early 80s caused patients to develop AI. You also may have aortic root abnormalities as aortic root dissection. Syphilis in the 1940s was a more common cause of AI as well. Marfan's, Ehlers-Danlos syndrome, rheumatoid arthritis, and ankylosing spondylitis. In aortic regurgitation, you get an incompetent aortic valve, and you get a volume overload condition that occurs very quickly in the left ventricle. This causes an immediate overload of the left ventricle, which leads to an increase in left ventricular end diastolic volume and a significant increase in left atrial pressures and pulmonary artery pressures. As a consequence, develops severe pulmonary edema. This is an acute AI. This is the more common cause for acute AI. You can see this in aortic dissection. As the aortic dissection progresses, it actually involves the aortic valve and causes the valve to all suddenly leak. So you're in a bad place to be, to say the least. You have already a torn aorta, plus now the valve is completely incompetent. Okay? As a consequence, you get acute AI symptomatology with acute pulmonary edema developing. In chronic AR, it's more gradual. You do get a left ventricular volume overload condition, but you do get some compensation by dilation of the left ventricle. This leads to increased myocardial workload, but you get a low aortic diastolic pressure, increases the risk for ischemia because the actual pressures inside here may actually be rising, which means your left ventricular and diastolic pressures are rising, increase your risk for ischemia. You actually see that left atrial pressures are staying normal or slightly elevated. It's not as bad as the acute AI. So you can see the differences. In the acute AI, you don't really see remodeling of the heart until in the chronic, on the other hand, you do see the chronic dilation taking place. Okay? What you hear in this kind of murmur is a diastolic murmur, it's a decrescendo murmur, okay, that occurs during diastole. You get chest pain, fatigue, shortness of breath, then syncope eventually develops. These are all bad signs. Magnitude and recursion volume will be the time available during diastole. Okay, the longer the diastole, the worse it gets. Okay, so it's heart rate dependent. You're actually better off in a more rapid heart rate than a slow one in AI. Okay, too slow, you spend too much time in diastole. You spend too much time filling the heart back up. The pressure gradient also across the aortic valve is critical. If you increase the SVR in AI patients, you make the situation worse. So not something you want to do. Okay. The less gradient, you can lessen the gradient and improve cardiac forward filling by decreasing SVR. What's the differences between acute and chronic AI when you're looking at pressure volume curves? Okay, in an acute situation, we'll just do the normal curve here first. Okay, this disease process is taking place here. In the acute process, you get a rapid filling of the left ventricle, so you get this kind of effect. Okay, eventually it comes out, okay, comes up. In this case, the valve tends to open more frequently, so you get this effect. Okay, so that's your acute AI. Okay. Now, in a chronic AI, you get the actual pressure load. The ventricle actually begins to dilate, which means that the compliance is actually becoming improved, or you get a higher degree of compliance. So the pressure over volume curve shifts over here. For the same pressure, you know, over here, okay, so that means that your volume is much higher inside your ventricle. Okay, you get the same kind of effect. It goes up, and it goes off. Okay, and let's go here. Okay, and then drops back like that. Okay, you can see right here. This is a pathognomonic of AI. You can see that the ventricle is refilling right away. There's no isovolumetric filling, and the isovolumetric is not isovolumetric anymore. It's actually refilling the heart right away. Okay, that's acute and chronic. Okay, does that make sense? Yes, sir. Oh yeah, lots of it. It increases myocardial workload for that heart. As soon as you begin restretching the heart muscle prematurely, you increase myocardial workload. The last thing that we ever tell you to do when you're doing hearts is that we tell you empty the heart. Okay, the empty heart is a happy heart. Okay, because the myocardial workload increases every time you stretch it. So you see a heart that's fibrillating and full, that's a worse place to be. If you see a heart that's empty and fibrillating, that's bad, but not as bad as if you're full and fibrillating. Okay? Management of AR is maintain preload. You want to decrease the afterload as much as possible without causing effects and dropping your diastolic pressure too much, because then you affect your coronary perfusion pressure. You want to increase your heart rate. By doing that, you decrease the diastolic time. The last one we'll talk about after this is the next one, which is tricuspid stenosis, I think, or tricuspid regurg. Treatment of AI is aortic valve replacement. Of course, the operative mortality is not low. It's around 4%. It's higher risk of aortic root replacement is needed. Medical treatment is a joke. You can't really fix this problem with medicines. You can try to give them time by reducing afterload. So dobutamine is a reasonable agent to use. Okay, this shows you how much regurgitation you're getting. You're getting a huge jet coming back. Pretty good echocardiogram showing severe AI. Management is avoid bradycardia, avoid increases in SVR, and minimize myocardial depression. And usually general anesthesia is fairly reasonable for this kind of procedure. Nitrous oxide, volatile anesthetics, high-dose opiates, avoid bradycardia, and neuromuscular blockers are pretty well tolerated most of the time. Monitoring is still the same old thing. Okay? The last one that we'll talk about briefly is tricuspid regurg. And tricuspid regurg is something that we're not going to talk about in a lot of detail because it doesn't occur very frequently. Okay, in the operating room, we're less than 1% of our overall caseloads that we see this. What you see in tricuspid regurg is you see a large, the valve actually remains open during systole, so you get a large V wave on your CVP. These people develop problems with liver congestion, and you can see a prominent V wave on their neck veins. Treatment usually can be done with some kind of medical therapy by reducing the actual pulmonary hypertension if you have it. Okay? These people have some more problems usually when we put them under general anesthesia. So regional anesthesia is more acceptable for these people. The reason that you're having problems with general anesthesia was positive pressure actually makes tricuspid regurgitation worse. So anything that increases pulmonary artery pressures will actually make the TR worse. Tricuspid stenosis is an enlarged A wave on the CVP. Okay, again, something that you don't see very often. Management of anesthesia, of course, is you got to be very careful with these people. Regional anesthesia is really contraindicated. The reason it is because both left and right ventricles are empty of volume. And as a consequence, if you give these people regional and you drop their volume even more, you can get yourself in really hot trouble. Even general anesthesia is a high-risk procedure in severe tricuspid stenosis because you still can't get enough blood volume through the pulmonary circulation. So this is one that's fraught with danger. Most of the time when we do these, we are going there to replace the valve. And we're not going to